Okay, awesome. All right, great. So I'm here with Dr. Sharma, infectious disease doctor, who's very busy. So I rotated with you, so thank you so much. And you're a wealth of knowledge, and I'm hoping that you can share some with the primary care,
Sure.
So we'll get started. So we're in the Northeast Pennsylvania, so you work at a hospital, I work at a outpatient. This is not the recommendations of our hospitals that we work for.
So again,
This is your own opinion.
as Saul said it, these are my own personal recommendations, of course, based upon the guidelines. These are again are mainly tools for you to kind of make a decision and an informed choice, so that you can provide the best standard of care and the patient care possible.
So we're going to talk about specific things, but you have an inpatient and you also have outpatient clinic. So I rotated you a few times at outpatient clinic. What's a lot of the things you see as an infectious disease doctor outpatient?
So predominantly, a lot of our practice. So if you see a standard infectious disease outpatient clinic, it is divided into consultations and follow-ups.
Okay.
So by consultations, I mean referrals.
Right.
So the follow-ups are essentially, majority of them are hospital follow-ups.
Right.
And patients who are on IV antibiotics discharged on that.
Right.
And HIV patients.
Right.
Some infectious disease providers also have travel
clinics,
patients,
right.
and some of them are also into adult immunizations.
Okay.
So disclaimer, I only treat adult patients.
Right.
So we have, from that standpoint, the referrals here in this area range from latent TB,
right,
Lyme disease,
right,
and sometimes because we have a heavy podiatry program here, so it's about new bone and joint infections here as well.
Right.
So majority we see all of that. I think our PCPs are doing an excellent job here to kind of shelve out and keep patients at bay.
Yep.
And they're doing an excellent job at treating them.
Awesome. Do you get a lot of we can't figure out what's wrong with this patient and they have fever?
We do, and that's called fever of unknown origin. It usually comes in after they have tried everything.
Yeah.
And I guess that's the reason.
Okay. So they say you're the smartest people in the hospital.
Yeah, sure. No. cut that.
All right. So let's start off with Lyme disease, because we live in Northeast Pennsylvania. So tick-borne illness, one of them. So Lyme is very common here. And people in the woods, they contract it, and they so it's very common. And I've had a couple patients, So the first line, so the tick has to. So okay, it says in the book that the tick has to be on for 24 hours, and then it transmits the the spirochete, and then if it doesn't get treated, it can cause secondary issues.
These are good points, y'all, because by itself, Lyme disease is a big entity here.
Yeah.
First, let's start with the prevention.
Yeah.
So I tell my patients that get a different set of clothing when you're going out.
Okay.
So that way you kind of already prepared.
Right.
A couple of my patients have told me that they put duct tape onto their pants.
Okay.
So it kind of helps from that standpoint with preventing the tick from going into.
Right.
Remember, the tick is going to enter from. It's stuck on that grass. It
Right,
doesn't jump up high.
Right.
So it could get in from the folds, the inner folds of your of the pants, and it could go up. And the third important thing, I mean, apart from using DEET-based clothing, I tell them is you come home, take the clothes out, put it in the dryer, hot cycle for 5 minutes.
Okay. Oh, so you're saying the tick can still be on the clothing, then you put it back on and you get the issue. So we see a lot of patients. I see a lot of patients who come in, they're in the woods or they went camping. They pull the tick out of the body. They're not sure how long it is. I just put them on prophylactic. I give them Doxy, 200 milligrams. I remove, the tick is usually out, but sometimes I'll get a piece of a foreign body, the head of it, whatever, so you have to dig it out. And then.
So yeah, that's right. You need to, if you're unsure about how long the tick has been there, or if it appears engorged.
Okay.
Right. Or it's been more than 72 hours, 48 to 72 hours. I go with 2 doses of 200 milligram of. So it's
2 doses.
It's a 200 milligram of doxycycline.
Right. So it's 200 times 1.
Yeah, 200 times 1.
Okay.
Yeah.
And it's safe. So
it's safe.
Doesn't matter if you give it together or separate?
I usually prefer together, actually.
Okay.
Again, you're giving someone doxycycline, 2 big things in this area. Make sure that they're not lying down after taking doxycycline.
Right.
And the second thing is, some people it can cause photosensitivity.
Yeah.
So they need to wear,
Yeah. I think I don't know if it's dose based, because I've had people where like it doesn't, like somebody's on Doxy for a month for something else, and then like later on they start having that, and then the laying down is because it causes esophagitis.
Esophagitis, yeah.
All right. So
so that's the part where you saw. The next part is,
sorry, allergy to Doxy. What do you use?
I think the second line agents which are shown to be effective are amoxicillin.
Okay.
Yeah.
And kids use amoxicillin.
Yeah. And not really a lot of Keflex and all that, even though ceftriaxone is the IV version.
Right.
But
okay. Sorry, you're going to say something.
Yeah. No, what I was saying is that then your next part comes in, right? A lot of your patients do not remember that a tick bite.
Right.
Remember, these are painless bites. Tick bites are not known to be, they're observed.
Right.
So so they come in and they see some rash.
Right.
Our textbook picture of the bullseye rash, we got to start to forget about it.
Right.
You can have concentrated non-bullseye rash, multiple places.
Yes.
My advice to the PCPs and in this area is, you have a patient in the tick season. Earlier it used to be after July 4th.
Okay.
I think we got to now push it, start a little bit early, May, June,
Yeah.
right? You have a patient that is coming to you with symptoms you cannot understand. Take a look at the back, because you could find multiple rashes at the back, and that could be the first indication.
We had a patient who had non-bulls, so just it was uniformly it was like 2 to 3 centimeters. She had them all over her family. They were like all over her body. They were sandpaper, flat. She ended up having, and all she presented with was crazy amount of diarrhea. And then it turned out her Lyme was positive. I never saw it like that. So, but what other presentations of Lyme? So obviously classic bullseye rash with headache.
We're looking at classic. You see a classic bullseye rash, you think it's Lyme. Don't even bother testing. Do it. Your clinical judgment is much higher because you're not going to know what to do with a negative test. Right. And the goal is you give. I see people being prescribed on 14 to 21 days. I think 7 to 10 days is more than enough. Yeah. Okay. You give that doxycycline and it should get better. Okay. Right. Suppose if we miss that part as well, some patients come with the secondary Lyme. Right. And that's we've seen patients at multiple levels. Disseminated, so multiple rashes, not a single bullseye lesion. Right. Number two, some of them could have heart block. Right. And then we go on to the tertiary complications of arthritis and encephalitis and. So common ones you will see are rash. The next common one probably is headaches. No, so after the rash, the next common ones in outpatient setting that you will end up seeing is I'm blanking on it, and facial nerve palsy. Oh yeah. So that's pretty common. Right, but that's without the because you'll get that with VZV, so that's gonna be without it. Yeah. So you got to keep that in mind. Right. Headaches, yes, it's common. Okay. And when we are entering the territory of neuro-Lyme, I think there are 2 tests which are absolutely needed: a lumbar puncture and a serum test, so that you can gauge the index. So I think to all the PCPs over there, I mean, if you're thinking of neuro-Lyme and if it's not an isolated nerve palsy, right, then LP is what we will need, because we need to calculate the index, and that's the time you put a referral in for infectious disease. Okay. So I really, that would be a lot overwhelming. Right. The good thing is that majority of the Lyme is treated with doxycycline. Right. Now, so we do ceftriaxone in refractory arthritis, in encephalitis, and sometimes, and I do that in heart block as well. Although doxycycline can work in that. Right. I haven't seen that much, but I haven't seen heart. I'm sure you've seen heart block, and that's like years later or months later or what? In some people, it comes months later. Okay. Years later is, I think, mainly arthritis. And again, these are very characteristic arthritis. It's not the all my joints ache. Right. I've seen one case with you. Somebody had a large effusion. Yes. Of a knee joint. It was. Yes. And it was obvious. And then so basically the spirochete basically settles in there and causes the effusion. Right. And then the whole goal is you're trying to prevent the degeneration of the joint further. Okay. So you basically call the orthopedic guys, have them take it, and then we need to document PCR over there to treat it. So let's talk about testing for a second. It used to be you would do an ELISA and then you would have refractory Western blot. Now we have a new test. We can't even do that anymore. We have a different one where it does like a ratio of IgM to IgG. I think I would still
What's that test? Are you familiar with that?
No, I don't even look at the ratio of the IgG and IgM. I think, is it by LabCorp?
Oh man, I'm not sure. But I mean, that's
because in
test.
Geisinger we are doing the screen, and if the screen is negative, right, then you can then we don't need to go forward with the Western blot.
Right.
The state recommendations and CDC recommendations are pretty simple.
Oh, so you're still doing that? So you do a regular, and if it's positive, then you Western blot, and you have to have 5 or 7, and then IgM. Yeah. So it's IgG, IgM. Interesting. We have a new test, and I talked to them about it, and they validated it. I'll find it.
Okay. Let me know. Yeah.
Yeah. So anyways, so
so you do the testing. If you see a rash, you think it's Lyme, don't do the testing.
Okay. Just try. I mean, a lot of times I'll just treat it anyways.
Yeah. And if you're not sure about certain symptoms, and if they're outpatient, and you think that could have been in the tick season and all that, you can do that.
Right.
Remember, if your patient is very, very sick when you're seeing them with high fevers, think of anaplasmosis, babesiosis as well. So you got to do CBC.
Because there's co-infections.
Yeah. Okay, yeah. CBC with diff is important.
Okay.
And a peripheral smear if the lab can do it.
Okay. And I actually had them make a tick-borne panel.
This is beautiful. We have a tick-borne panel.
Yeah. You have a tick-borne. Yeah. But if they're not sick, then I'm not doing everything testing. I'm just going to do Lyme, because So now you'll get this. I mean, you get this a lot. I'm sure people will try to click. Okay. So they were having some non-specific symptoms. Somebody tested them for Lyme. It was positive. They must have had it for years. All right. So now they blame everything they have on Lyme. Okay. So you treat them now, and let's say you give them, I don't know, 21 days. Let's say, I don't know.
So what I do is that's the time I talk to the patient. At some point they've been treated. These are called the chronic Lyme or the post-Lyme disease syndrome. Right. Still a lot of controversy over it. There are two sets of there are Lyme advocacy groups, and then there is Infectious Disease Society of America. I follow the guidelines from the IDSA. The thing is, if these symptoms are non-specific and you cannot attribute it to something, if they are pretty recent and in the season, I give them another course of doxycycline. Again, I do 14 days only. Okay. I rule out CNS disease, heart disease, and bone disease.
You're gonna do an LP on that?
No.
Oh, you don't have
through my systemic.
Exactly. Because if they're having CNS disease, they're gonna have symptoms, right? They'll have at least well, not encephalitis, but maybe some meningitis symptoms. What symptoms do you expect with meningitis? Does it have to have fever, or can they have just head? They
have headaches.
They have headaches.
They have altered mentation, on and off, right? Okay, and they do have nerve palsies, 6 and 7.
Okay.
So facial droop, and all that.
Okay. Now, if somebody gets treated, so they had it for who knows how long, they get treated, even if we treat it for 21 days, let's say, the spirochete should be gone. So it's not like herpes, it's not like hepatitis B, where the spirochete is still hanging around.
Yeah, and that is what I tell most of my patients with chronic symptoms, because they feel that the version is that the spirochete by itself is like it's corkscrew shaped, so it goes in, drills into the joints and all that.
So it's not that true.
So I tell them it's not.
So if they get better, you don't have to worry that the spirochete is living somewhere else and it's not treated. And the reason you would treat with IV antibiotics for neural involvement is just because
penetration.
Okay. All right, very good.
That too also nerve palsies isolated can be treated with doxycycline.
Okay. Now there's other doctors out there who will treat with IV ceftriaxone out afterwards, and for a month afterwards. I mean.
Yeah, that's what I tell a lot of my PCPs. There is no data on that.
Okay. Yeah. But I mean, it's probably not going to hurt.
Yeah. But the thing is, remember, it's going to be an IV line.
Right.
And you're causing central line associated infections, and you can do that, but it's really not much.
Is there any role for? Have you seen people using vitamins or something like that and getting better?
I always tell them that if it's herbal supplements and it's not contraindicated, use it. And but what I do is, a lot of our patients are with chronic symptoms. I tell them rule out vitamin D deficiency. Okay. Rule out sleep apnea.
Good.
Hypothyroidism.
Right.
And I tell them that to start with low impact exercises.
Okay.
Start aquatics. Right. The JCC, YMCA over here, they do that, and just get back into the system.
All right. So the bottom line is this: you've seen a lot of patients who have Lyme disease that was untreated for a long time, and then when they're sick, you see symptoms. You see an effusion, you see
heart blocks, meningitis,
right,
and nerve palsies.
I've seen. Okay. So that's what you would expect. Vague symptom, like feeling tired, is not like a chronic symptom of Lyme. Okay, I think we killed this thing, so we're good.
Yeah.
All right, let me talk to you about. We have common diseases in the upper respiratory system that are presenting for us. So we get a lot of colds. Somebody comes in with a viral URI, and then they have secondary infections from that. So let's talk about like otitis media, right? Usually it's not going to come on its own. It's usually secondary to upper respiratory infection. So what's the pathophysiology of what you would expect in that case? Like, how did otitis media come from upper respiratory infection?
I think you got to look at the eustachian tube to be open on both the ends, right?
Right.
So initially you have the viral cathara, or that's what it is called, viral aspect, where you have a high burden of bacteria. No, viruses over here. That causes difficulty in draining out. Then you have the oropharyngeal structure, nasopharyngeal and the oropharyngeal area as well. Oropharyngeal has got more bacteria.
Right.
So that is from where, and any viral infection is going to inflame that.
Right.
So that probably could lead to a bacterial colonization.
Right. And then you have fluid that just sits there, that turns into an infection. Okay.
Yeah.
And then at that point, we'll look in the ear, we'll see an erythematous tympanic membrane. Then there's a role for antibiotics.
Yes.
Then we have otitis media with effusion, where it's not, where it's just hyperemic. That could turn into an infection, but it's not necessarily there. And then you would expect, we know we could go Stanford Guide and find the exact antibiotics, but is that the same pathophysiology for sinus infection?
Yes. Streptococcus, Haemophilus, Moraxella.
Okay.
So.
And then,
but again, the question here is, if you see effusion, remember, antibiotics can only do certain time.
It's not going to remove an infusion.
It cannot remove an infection.
I talked to an ENT, and he was arguing that anytime you're treating for sinus infection, you should probably be giving steroids at the same time to decrease inflammation, so you can allow for proper drainage.
I think that's fine. I do that. I've started to lead towards the steroids as well simultaneously along with the infection, but always with caution, because you could have immune suppressed patients.
See, let's talk about that just because we're on topic. So I read somewhere recently that there are better outcomes for people with pneumonia inpatient who are treated with steroids as well. Why isn't it doesn't, I mean, I guess you're doing a short course of steroids, so you're not going to knock down the immune system to the point where it can't fight
where it doesn't depress it further so that you can get superadded.
And then we use it for patients who have bad pharyngitis and they have large tonsils. So it's probably not, I mean, for a short course, maybe 5 days or something like that. It's not a bad idea. Okay. You've seen a lot of complications. I mean, we don't expect these, but have you seen complications from otitis media where they end up in the hospital?
Mastoiditis. I don't see much about it. I think because our PCPs are doing a great job with everything that they're doing, ENT referrals and all that. But yeah, you could have mastoiditis, and that's where I start to get worried about it, because from there, meningitis is not far away.
Right, and that's pretty obvious. They have mastoid tenderness.
Yeah.
And then sinus infections, have you seen that going anywhere?
Not many in the outpatient setting. The outpatient setting, actually, the ones that we get is chronic refractory sinusitis.
Right.
So, again,
that's an ENT. Yeah.
Yeah.
They have to do a sinus.
Yeah. So, and mostly these are from ENT colleagues.
Okay.
And they're asking us about their recommendations that they've tried. So again, it's just you basically make sure there is a good drainage.
Right.
And then basically collect the drainage and treat accordingly. But there's no role for long-term antimicrobial therapy over here. So we kind of sometimes flip antimicrobials. Sometimes there's antifungal use. So.
Right. Yeah, there are fungal infections. Yeah.
But acute sinusitis, again, the guidelines are the same. You hold antibiotics until you're at least around 10 days and start getting better. Or if your drainage consistency changes to something which is thicker and more foul-smelling.
It's a tricky diagnosis because not all patients have fever all the time.
I know.
And not all of them have tenderness all the time. And so, you have to kind of piece it together. Okay. And then do you see a lot of complications from, how about treatment in outpatient settings for these conditions? Do you find that there's any problems if you overtreat, or what's your opinion on that?
Again, from infectious disease standpoint, we would not like people to overtreat beyond, because if it's not getting better beyond 7 to 10 days, then really we're missing something. So we need to re-image so that we need to figure out, are we missing a collection, or our antibiotics are not, so the image to find some collection or something that we can get, so that we can collect it, and are we targeting the wrong bug and with the wrong drug? So that is why at that time I say take a pause, get some imaging.
Okay. All right. In the mouth, dental prophylaxis. I know, just jumping to a different topic, but
it's a simple thing that I look at it. If you have, I tell my patients, if you have jewelry in the heart, then you need the prophylaxis. So anything that is prosthetic that you have, so those patients need dental prophylaxis. Our dentists are pretty good over here with prophylaxis.
Yeah, but I keep getting patients asking me for prophylaxis for things that are probably not indicated. But let's run. So any type of mechanical or a prosthetic valve. And then I was reading also for EVAR or any type of endovascular.
So anything, just think of it, prosthetic material, prosthetic valves, some surgeries which required some kind of meshes or something else to be placed. I kind of treat them as, so that's the patient risk. Right. So those guys should get it for almost everything. Then there is a procedure risk. Right. So there are certain procedures that do not need it. Colonoscopies do not, cystoscopy alone, but with a biopsy, it's a separate issue. So there's the ADA has got very clear guidelines. This.
No, but just regular dental, they're going to go for a dental tooth extraction or something like that. Or they're going to have a cavity filled or something like that. I mean, so they're going to introduce bacteria into the blood. It's going to happen. So those patients will get it. So let's see. I get a lot of like, hey, I have a knee replacement. I have none of that. That's not indicated at all. So did it used to be indicated, or?
I think they were, and then they changed the guidelines to include patients with mainly prosthetic material.
So, but cardiac stent is not one of them.
No, it's really not one of them because that's main coronary.
Right. So it's not that. And then your treatment is going to be 2 grams of amoxicillin prior to the procedure, just whatever, an hour before, whatever it is.
I think they say 30 minutes before, 30 minutes to an hour before.
So I just prescribe it, they just take it beforehand and they're done. And you don't have to do anything afterwards?
Nope.
Okay, and this is all to prevent vegetations attached to the heart?
Because every time you brush your teeth, every time there's dental cleaning, there is a transient bacteremia. So basically this helps reduce the inoculum before it gets stuck on the prosthetic material. Because remember, prosthetic material is where the antibiotics and all are not going to act on.
So you got to just prevent. You want to kill the bacteria before it has a chance. Okay, so that's good. Okay, elderly people with UTIs.
Oh wow, this is I think the goal here should be to avoid thinking that every time there's a change in mentation it's from a UTI.
Right. So we're in more outpatient, so we don't get as many as you, because you get a lot of patients showing up in the ER. And then the elderly are change in mentation. It's like, oh yeah, it's a UTI.
So believe it or not, elderly will have the similar symptoms, right, than everyone else, except that just be aware that some elderly could feel more cold rather than have fevers. So it says the older they are, the colder they are. So
and they may not have fever, right?
Yeah, they may not have fever.
But they should get, well, for example, they are definitely more prone to this, especially women, right? Because they have vaginal atrophy, they don't have as much estrogen, so you have migration of bacteria. So will they have the same dysuria urgency frequency or not as much?
Yeah, they would. They would, depending upon how much they can. So we're talking about someone who doesn't have a Foley catheter, someone who doesn't have a suprapubic. So yeah, they would have the dysuria urgency and frequency, and they actually will be able to tell you.
Okay, because the guidelines for treating UTI, I mean, I think there's guidelines that say basically if they say they're having symptoms, just treat them.
Yeah. So you don't treat asymptomatic bacteriuria. So basically, go for the dictum which says treat the patient, not the petri dish.
Right.
So.
Right. So if they say, hey, just test me for the UTI, but they're not having symptoms, it's a waste, right? But if they're having symptoms, then just treat them, and then you could check the cultures, yes or no. But okay, and then you could do a culture just to see what's going on, and then to prevent these from happening. So in females, you might prescribe vaginal estrogen.
That's what I do all the time. So postmenopausal atrophy, postmenopausal women are more prone to it. I prescribe vaginal estrogen, but there's the history that I take is personal history of breast and endometrial cancer, family history of breast and endometrial cancer. If they have any one of these, then I think I check with the GYN. Because I know it's not going to be much as compared to what.
No, so you can't do it every week. You can't do it every day, because then they'll start bleeding. You have to do it like twice a week, and you can change. Okay, good. Yeah, but that'll bulk it up so they don't have migration of bacteria.
And then the estrogen gets the good bacteria back, and then it works. Some women also use lactobacillus casei, CASEI.
Oh yeah.
Yeah.
What is it? Oral?
Yeah, it's an oral thing. I just tell my patients to take yogurt. Greek yogurt is always best.
Okay. And in men, not common to have UTIs in men.
Yeah, but IDSA guidelines changed last year, and they talk about men also not being complicated anymore.
Really?
Yeah, but accepting, again, it's uncommon, but we used to always put men as complicated UTI.
Right.
The duration in men is also reduced. Someone who does not have urethral stricture, recent cystoscopy, running Foley catheter.
Right.
So
mostly in men, if you're going to have it's probably secondary to BPH. They're having stasis of urine inside. Yes. They have trabeculum in the bladder, and then
in men always look for the sleepers. I will say.
What does that mean?
The prostate.
Oh, prostatitis.
Yeah. So he could have a chronic prostatitis, and come out with it. So acute is easier. They will complain about it.
Right.
But always ask for the symptoms of pain in between the testicular area and the rectal opening. There's a small little area over there. It's called LUTS kind of syndromes.
Yeah. And then you can do a prostate. I mean, if I'm going to diagnose it, I try to do a prostate exam. Have you heard that there's I just read about this. I forgot the plexus. There's a plexus that runs from the bladder to the lumbar spine. And you can get seeding of bacteria that could cause. I have to look into it.
Okay. So you're more knowledgeable.
No. I just read it was a crazy thing. All right. So that and then go to antibiotics for these.
So the first go-to is if you know your patient calls you, you can tell your staff that someone calls with UTI, just order a urine analysis, urine culture.
Okay.
Right. You can go ahead with Bactrim. If they're able to take it. My
first
go-to is 5 days. And as you wait for the cultures. Right. Or go to the last urine culture that the patient had
and see.
And then you can go for that.
And then what about so Bactrim? We're moving away from Cipro.
Reason being, in elderly, it can cause encephalopathy. There is a black box warning of people. It can prolonging QDC, and the third most important part I think is the susceptibilities are gone.
Okay.
Yeah, and the tendinitis fourth.
Right. Okay. So you're not doing. I mean, you could use it for. I know old urologists they use a lot. But,
yeah.
Okay. I started using Keflex 500 BID, and then
I would change it to TID if you're treating.
Really?
Yeah, because of the or in the case you use Sevdenir, which is 300 BID.
Okay. Okay. And then what about the nitrophenatoin? So macrobid?
Macrobids I use. There's sometimes phosphobid I use. Phosphomycin I use. So it's always best to wherever you're working, kind of contact the microbiology department of the hospitals near you.
Yeah, that's you.
And we'll be able to give you our antibiogram.
Gotcha.
So once you have the antibiogram, you are able to make that informed choice.
Okay. And then if there is resistance, they should not get better, or do they get better and then get worse, or what?
No, they should not get better.
They should not get better.
Yeah.
Okay.
Some antibiotics do exert the anti-inflammatory effect, so you could find
like
got better, but it didn't go, and
Okay.
By the time you'll have the cultures. So remember, the urine analysis, urine cultures are the key.
Okay. And then people who have back pain, a lot of times they come in, they say, "Oh, I want to make sure it's not my kidneys." Now, if somebody's going to have pyelonephritis, it's impossible without a fever, right? Okay. If somebody's going to have kidneys causing back pain and it's from something else, if it's from stone, you're going to have hydronephrosis. There's no way you're going to have. So you just do CVA tenderness.
That's the classical part, CVA tenderness. Yeah.
So. Okay, good. I think we're covering a lot. TB.
Latent TB.
Can we talk about it quickly?
Yeah. So now, number one thing, if you think the patient has active TB, Department of Health has got a beautiful website there. They have people who you can directly contact and refer the patient over there.
Okay.
Latent TB is one way you can do quantiferon, and if you find if it's positive, Department of Health does take care of that as well.
Right. So let me back up. So most of these cases, for me at least, it's going to be just a screening. They need to get screened for their school or whatever it is. So we either do the serology, the serologic injection, or we do the quantiferon. Most of the time, it's serologic injection. So if it's positive, then you're saying if that's positive, we should do a reflex to quantiferon.
So it's like competing chalk and cheese, right? Comparing. If any one of them is half positive, also
just assume it's positive.
Assume it's positive. Okay. Then go with the history, and in the history you can figure out that what work did they do, and if there is people contact,
Okay.
Go for it.
So if they were living overseas, if they had somebody else who had it, that means that they were exposed. Now, just because they had exposure doesn't mean they actually, they could have latent, meaning they got exposed, but their body overcame it.
Yep.
That didn't overcome it, but they never got active TB.
Yeah, they never got active, and the chance of them getting an active TB, I'll tell you, there's an unofficial calculator. It's called McGill University latent TB calculator. So it gives you what are the chances of acquiring active TB.
Right.
So that is patient specific. But what I can tell you is that a lot of people feel the word latent means it's gonna just like a volcano, it's gonna erupt at some point. When we do the screening, we kind of offer them the treatment for latent TB because if they do become immune suppressed,
right, it can come out.
It can come
But
out.
what's the chance of, if somebody was exposed to TB, never had active TB, what's the chances they will become active?
That's where the calculator helps.
Okay, but what's, like, if you had to go off the top, if somebody's completely healthy and they're 40,
Yeah, the chances are much lower.
what is it? Like less than 1%?
Yeah.
Okay, so that's pretty low.
Yeah.
And then if they're latent, there's no chance of them passing it on to anybody else
not at all.
because they're not active, so they're not breathing it out.
Yeah, yeah.
But it is in their body in microscopic areas. And then you're doing an X-ray to show that they haven't had active TB turned into a Gone complex. So if they had a Gone complex, that means they had active TB at one point.
So that means it needs a little bit more of sputums and all that to see whether they're actively having that. That's something.
Okay, so they're positive. You do an X-ray, and they never had symptoms of active TB.
And the X-ray is fine. Then you treat for latent TB.
Then you're treating for latent TB. Okay, and they don't have to wear masks, and they don't have any problem with that. Do you have to test people around them? Okay, so we're good. And then the treatment is nowadays in America, where we live now.
You have about 9 months of INH.
Okay.
6 months. You have 4 months of rifampin.
This is
oral. Yeah, or there is, if you combine both of them, then there's basically 12 weeks of that. But I usually do rifampin.
All right, so I'm going to send them to you.
Yeah.
But that's just the okay. I think that's good. All right, let's talk about some small things, and then I know you're busy, so I'm going to let you go. Let's talk about, like, I don't even know if you see this a lot. So there's a lot like lice in school.
Yeah, I don't see that much.
You don't see that much.
That's the only thing.
And you don't see complications from that either. Okay.
Scabies. We do see scabies, but one-off scabies and all that.
Yeah. Okay. What about okay? How about diarrhea?
Diarrhea. So you have a patient with diarrhea. The first question here is antibiotics.
Right. Because you're ruling out C. diff. Okay.
And the next question is a good epidemiological history.
Right. Travel.
Water supply and travel.
Right.
So food, water, travel.
Okay.
So if they are able to give you that answer.
Right.
Geisinger has got excellent PCR system. It's called gastrointestinal pathogen panel and regional parasite screen.
Oh, nice.
So you can send that along with the C. diff.
Okay.
Right. So you have that answer pretty quick.
So, because maybe I'm just not aware of the ones we have, but
stool for ova parasites is actually gone.
Really?
Yeah.
So what
in Geisinger system at least, the reason was that it had a lot of, you could still not rule out, right? So you basically are doing PCR based systems now.
But let's say you have somebody who is here, let's say they don't have, if they're going to have an infectious diarrhea, I mean, most of the time it's probably viral, but if it's going on for more than a week, or if you have blood in it, or you're having to run about, then you have to start thinking bacterial. Yeah. And so what are the common ones that we're going to find that?
Shigella, Salmonella. Salmonella is the most common that I've seen over it. Salmonella, Campylobacter, anything that is related to salads, so the diet of the people around.
So it's a food, okay, yeah. It's a foodborne.
And again, I will be very clear about it. There is no way to blame that, I went to the particular Delhi and that's where I could have picked it up from. So I don't get into all that stuff.
Okay.
So like, you have the diarrhea, we need to fix that.
Right.
Water supply here. So Salmonella, Shigella, Campylobacter, norovirus. Right. And enteroviruses.
Right.
What else am I missing?
So oviparasite's not as common.
Yeah, the parasitic is not really as common.
Okay. And then your treatment is azithromycin?
Most of the diarrhea is self-limited, so I really don't treat.
Well, after a week.
After a week, I know. So then what it tells you is that if they are causing debilitating symptoms, right? And it's a very frustrating history that you have to keep on thinking about the stool frequency. The frequency is the last one to change. The consistency is the first one that gets better.
Okay.
So that's...
So meaning first it's watery, then it starts becoming more formed, and then it'll become less frequent.
Yeah.
That's a good rule.
So you can, azithromycin is one of the agents that I use.
So 500 3 times for 3 days. And then you can use Imodium, and that's not supposed to cause any problems.
No, I usually avoid Imodium until I've treated with antibiotics, but
really?
You can,
Okay.
At C. diff, I recently started to use Imodium only towards the end of the treatment.
Okay.
But you can use Imodium.
Okay.
But you got to be careful. It's just.
And then with the diarrhea, you wouldn't expect abdominal tenderness.
Shigella, yes.
Shigella, yes.
Some Salmonellas you would. But Shigella would be really sick.
They have blood, right?
So they're more blood or dysentery. That's what they have. Basically it's sloughed off, and that's going through. So those guys are not going to be.
Okay. So they're pretty sick.
They would be travelers, really.
Right.
Right. And Salmonella is I mean they do have fevers and all that. So.
Okay. I think that's good. I think that's most of what we got.
Oh yeah, there is a testing that is done in LabCorp about Rocky Mountain spotted fever.
Oh yeah.
It comes back as positive, negative. I do get some referrals like that. I still rely on the history.
Okay.
It got to be over there.
Yeah, you're the king of history and knowing what's happening.
So we got to understand that with the testing, the patients get nervous.
Yes.
Right. And Rocky Mountain, I would like to say, is very, very severe disease. You know, it's got a high mortality. So if the patient survived all that, there's very little chance that they still have the Rocky Mountain spotted fever with them.
Right. Okay, that's good. All right. What condition? We're going to finish off with this, but what conditions? No, we're not. I just want to know what you think clinically. What conditions do you think are missed in primary care that we could do a better job of?
No, I think it's harder, right? I cannot quite understand how their schedule, but I would say HIV and sexually transmitted infections in this area.
Right.
It is still very difficult to go for a sexual history.
Yes.
Right. So we stop at, oh, have you had sex, or do you have a sexual partner? So it's asking about partners, preferences, and protection.
Okay.
If you get 3 Ps, you will be able to get history, and that's where I think syphilis has seen a huge jump in this area.
Right.
And PrEP, because those are the ones, if I feel the pre-exposure prophylaxis.
Right. For HIV.
MSM.
Yeah.
I think screening them for HIV is big. This is what we need. I in fact read yesterday that about 11% of HIV patients living with HIV do not know that they have HIV. So a good sexual history and all that is extremely important.
Mm-hmm. Yeah, there's now a push, and it's even on our metrics to have a one-time in your lifetime HIV testing, once in your lifetime hepatitis C. But then you have like a 50-year-old lady who's like, listen, I've had one partner, I don't work in health, like there's no.
So that's the time that's where the PCP is equally more important. They've maybe not at the first visit, but at the next subsequent visit.
We should be pushing that.
Yeah.
Really?
Yeah.
You've seen cases where somebody you don't know where they get it, but they got it.
Yes.
How about, so we only do hepatitis C and HIV, that's the recommendations. Nobody recommends Hep B screening.
I think because Hep B is not that common over here. But remember, it's one of the most nastiest ones, so I would still recommend hepatitis. Really? So get the hepatitis B screening to vaccinate them, to immunize them. Think of it that way.
Okay.
Because Hep C has got. So
what, you're going to test you're going to test antigen?
Antigen, yeah.
Okay, so you'll order
hepatitis B surface antigen.
Surface antigen. And then, obviously, if that's positive, you got a problem.
Then yeah.
Yeah, and then if that's negative, there's a push now to vaccinate because their thinking is they weren't vaccinated as.
So remember, HIV has got good medications. Hep C has got excellent medications. Hep B still does not have. We're still stuck with the same ones, and it's not easy to eradicate that virus.
But why, for somebody who's at low risk for contracting hepatitis B because they don't have sex with other people, they're not having IV drug use, and they're not working in healthcare? Why are we pushing so hard to vaccinate them?
I think it's in the long run we do not know, right? The patients would be a low risk now, but they could become a higher risk at a certain point.
Okay.
So you just finish up and immunize them because that's the safest and the easiest treatment that they can get.
Right. I mean, because that's when you're looking at the population as a whole.
That's population health is what I'm looking at.
Yeah. Okay. I'm not disagreeing. I'm just asking. And then okay. Yeah, we didn't talk about STDs and stuff like that.
STDs are big. Somehow getting into the mold of asking, kind of I would recommend, if you're your staff and all that, you guys sit down and then look at that CDC, STI, sexual history, the questions.
So they have recommendations.
They have brochures too.
Well, they have recommendations for women to get chlamydia testing. I'm not sure about GC. I know chlamydia for sure. And then for the guys, I mean, you talk to them and be like, if you're sleeping with more than one person or you're worried, you can get it. I just offer it to everybody who's younger for sure.
Got it. STI, syphilis, chlamydia.
Right, so syphilis,
gonorrhea,
GC, chlamydia, gonorrhea, HIV.
Hep C.
Hep C.
These are the 5 big ones, and then Hep B. The Hep B is my...
So you just do a hepatitis B antigen?
Yeah.
Okay, that should be enough.
Yeah. I think in this area, syphilis is that big elephant.
Because they could have it, you wouldn't know.
Yeah.
It's just eating away.
Yeah. Mm-hmm. And it all stems from the fact so this is one thing that is missed. Second thing is taking a good allergy history of the antibiotics.
Oh yeah, you're a big guy there.
So these two.
I always tell people, you put people in the ICU, give them penicillin, like what was it? What did you give them? Zosyn.
Yeah.
And then there were you had like less than 10% that actually had a reaction?
People outgrow their allergy.
Oh, they outgrow them.
Yeah, and then 5% of them, and if in a history, sometimes you will find out that they have taken other forms of penicillin.
Yeah.
So these are the two things. So it all boils down to. But anyway, and
but I'm not going to be the hero that just says go home and try this medication and see what
you
happens.
don't have to. You can find out in your note. You can take that history and write down the one question: how old were they when they had that infection? When they had that allergy.
Yeah.
What happened at that allergy? And by what happened is, were they taken to a hospital, or did they need steroids and all that stuff? And lastly, have they taken other forms of penicillin like amoxicillin, cefdinir, cefepime, all that? And if they haven't, and they don't know, just put the name of the pharmacy. Allergy and immunology can help you out, because we need that. We're using second line, third line, and we're getting into antimicrobial resistance.
Right. So let's just go over it because you brought this up. So people have a penicillin allergy. There's only a 10% cross-reactivity with cephalosporins.
5 to 10, yeah.
So, or less than that, yeah, less than 10%. So you would feel comfortable, let's say they have a positive strep test, I can give them something else, or I can give them a cephalosporin.
So at that point, in fact, we have a tool that will grade them into low risk and a high risk. Suppose if they've tolerated a form of cephalosporin.
Yeah, of course. If they have it, that's an easy one.
If they haven't, then in that case, as a PCP, I don't want you to take that chance. If you assess, and if they say, if it's a rash, it's a low chance, right? If there was blebs and throat closures, that's where I would say no. Send them to an expert and go for it. And in the meantime, use another antibiotic. Cross reactivity. If they have penicillin allergy, yes, I think you're kind of good enough to use cephalosporins, but you have to verify what they had. Right.
But a lot of these, the nature is the problem. They're not sure, So it's really.
So that means if it's a childhood allergy, you're kind of safer. So in that case, you give it over there at that point.
Give it in the clinic, and then call you if they have a reaction.
So it's hard. So that's why use the third line if you don't want to, and for strep, and refer them to an allergy and immunologist, because they will be able to do a graded
you trust that?
Yeah.
Okay. Yeah, because there's so many people that you're having to give clindamycin in those cases.
Yeah. I don't want people to really be uncomfortable in outpatient setting. The providers. So referral.
No, we want to remove it. Yeah.
So my pet peeve here is that the history is only you have an allergy to and done.
Okay, so how about this? If they say I took it once, I had an allergic reaction, we don't have to worry that we had a rash. We don't have to worry that the next time they've now had exposure, the next time we give it, it's going to be worse.
It could be, but most likely if it was a childhood allergy, you have outgrown it, and that's where the allergy guys can help you out.
Okay.
Yeah. Things like diarrhea and all that is not an allergy.
No, that's not allergy. So that's an appropriate referral to an allergist if they have I had somebody who had like 15 different allergies to antibiotics. I said, this is ridiculous. You got to go there and figure it out. So, but I haven't routinely sent people who just have.
I would say send it. And then you will realize that once their allergies are delabeled, it is much better.
Right, because this is the bane of your existence in the hospital, is not being able to give regular allergy.
Yeah. And people not taking a complete history. It's just they shy away from allergy history and sexual history.
Do you have allergy to sex? All right, I think that's good. So maybe we'll do this again sometime, but I really appreciate your time. Thank you so much.
Thank you very much.
All right, awesome.
And our audience of one.